You walk into the pharmacy, you've been on the same medication for 3 years. Rheumatoid arthritis. The drug works, your symptoms are controlled, your doctor hasn't changed the prescription. Your insurance is active. Same card you've been in your wallet all year. You hand over the card, the pharmacist types, pass, types again, you watch their expression shift. I'm sorry, they say. This isn't covered anymore. You pull out your phone, same insurance, same plan, same employer. Nothing about your situation changes. What do you mean by it isn't covered? Your plan switches you to a biosimilar. If you want the original drug, it is not on formulary. We can fill the biosimilar for you, but I will need to contact your doctor for a new prescription. Did my doctor approve this? The pharmacist shakes their head. No, your PBM did. My what? That confusion, the moment where a valid prescription collides with an invisible wall, is a pharmacy counter mystery. And it is not a glitch. It is a system working exactly as designed. Because in the United States, where a doctor writes a prescription, it is not the end of story. It is the beginning of a negotiation you didn't know you were part of. Between your doctor's clinical judgment and the drug in your hand sits an entity most patients have never heard of. The Pharmacy Benefit Manager, the PBM. 3 companies control roughly 80% of all prescriptions filled in the country. They process drug claims for over 217 million Americans. They negotiate hundreds of billions of dollars in rebates. They own the largest specialty pharmacies. They decide which drugs to cover, at what price, under what condition. And they do it all from a server room, never touching a single pill. Last time we talked about insurer. Very timely, United Health Group this week reported over $6 billion in net savings for the first quarter of 2026. On the surface, the stock price has risen for 10%, but buried in the earnings release was a different story. Optum Rx, the PBM division, came in about $1 billion lighter than Wall Street expected. For a decade, PBM division was the untouchable profit engines of U.S. healthcare. Now, the largest PBM just missed by $1 billion in a single quarter. That miss is a signal. The ground is shifting, and today we're answering one question: who really controls your prescription? Not who writes it, not who makes it, not who sells it. Who controls whether you get it, where you fill it, and what you pay? The answer will take us inside the most powerful and least understood intermediary in the U.S. healthcare. Welcome to Summerlands. I'm your host Eva, and in today's episode, let's talk about who really controls your prescription. Let's start with what access is supposed to look like. Your doctor diagnoses a condition, they evaluate the options, they choose a therapy based on clinical evidence, side effect profile, your medical history. They write a prescription, you take it to a pharmacy. The pharmacist fills it, you pay your copay, you go home, you get better. Simple, clean, and clinical. Except that it is not how it works anymore. In 2024, Medicare Advantage insurers alone made nearly 53 million prior authorized determinations. 53 million times a doctor wrote a prescription, and before the patient could receive the drug, the insurer, or more precisely, the pharmacy benefit manager working on behalf of the insurer, had to approve it first. Prior authorization. It is supposed to ensure appropriate use, make sure the drug is medically necessary, prevent waste, promote cheaper alternatives when they are just as effective. It sounds reasonable, but in practice, prior authorization has become a bureaucratic government. Your doctor's office calls the PBM. They submit a clinical justification, sometimes pages of medical records, lab results, diagnostic codes. They wait days, sometimes weeks, and often the answer comes back denied, or try these other drugs first. This is called step therapy. Fail first. Your doctor prescribes drug B because they believe it is the right therapy for you. But your insurance requires you to try drug A first and document why it didn't work, or worse, that makes you sicker before they will cover drug B. Even if your doctor has clinical reasons to believe drug A wouldn't work for your particular case, even if you tried years ago on a different plan and had severe side effects, the requirement exists in the formulary. The PBM's master list of covered drugs, and the formulary has its own logic. A logic driven not just by clinical evidence, but by financial arrangements most patients never see. And here's a real example that play out across the country. By 2025, all three of the largest PBMs, CVS Caremark, Express Scripts, and Optum Rx, make coordinated decisions to exclude the original version of Humira from their major commercial formularies. Humira, a biologic drug for rheumatoid arthritis, Crohn's diseases, psoriasis, one of the best-selling drugs in the world. Patients have been stable on it for years, and overnight it vanished from coverage. What's the reason? Biosimilars, higher similar versions of the drug, had entered the market. You think that would mean cheaper options for patients? More choices? Lower costs? But here's what actually happened. The big three didn't pick the most affordable biosimilar on the open market. They picked biosimilars marketed by companies they own. CVS preferred Cordavis, a private label brand owned by CVS Health. Cigna preferred Krylant, owned by Cigna's Evernorth division. United Health preferred Nuvilla, owned by Optum. The PBMs used their formulary power to steer patients away from the drugs their doctor prescribed and toward a private label product they own without the doctor's input, without the patient's consent, purely as a financial decision. Your doctor writes a prescription based on years of medical history. A corporate entity sitting in the middle steps in and say, "No, you have to take the version we own." That's formulary control. And then here's the human cost. According to a pharmacy we published in April 2026, 78% of patients reported facing insurance denials that delayed or prevented care. 70%. And when patients try to appeal, the process is so time-consuming, so opaque, so exhausting that many simply give up. This is a term for this in-house policy: rationing for inconvenience. You're not technically denied. You're just made to work so hard, calling a doctor's office, waiting on hold with the PBM, submitting the same forms 3 times because the fax didn't go through, that you run out of time, run out of energy, or run out of options. Meanwhile, the drug exists. It's sitting on the shelf 3 feet away from you at the pharmacy counter. But the system says, wait, or no, or if only if you use this pharmacy, take this other drug first, pay this price. And now let's talk about insulin. Insulin is a hormone that is manufactured for over a century. It is not a new experimental biologic. It is a life-saving medication for millions of Americans with diabetes. The production costs are relatively stable. And yet, between 1999 and 2017, the list price of Humalog, one of the most commonly prescribed insulins, rose from about $21 to $274, so a 1,200% increase. Not because of innovation, not because manufacturing costs went up so much, but because of the rebate game. Manufacturer raised list price to fund rebates paid to PBMs. PBMs demanded higher rebates in exchange for favorable placement on the formulary. Manufacturers who didn't pay up risked being excluded entirely, losing access to millions of patients. List prices went up, rebates went up, and the patients who bore the cost were the ones who didn't benefit from rebates: the uninsured, the underinsured, and anyone in a high-deductible health plan who had to pay full list price out of pocket until they hit their deductible. By 2019, 1 of 4 insulin patients in the United States reported rationing their medication because they couldn't afford it, skipping doses, splitting vials, Rationing a drug that costs a few dollars to manufacture. In September 2024, the Federal Trade Commission sued the three largest PBMs, alleging they had created what the FTC called a perverse rebate system that artificially inflated insulin prices and harmed the patients who needed the drug most. The lawsuit is still ongoing, but the pattern it describes, high list price, high rebates, and the patient caught in the squeeze, isn't unique to insulin. It is the underlying logic of the formulary system. And then there is a specialty steering. Let's say you are prescribed a biologic for Crohn's disease. Expensive drug, $40,000, $50,000, $60,000 a year. Your insurance covers it, but only if you fill it at a specific specialty pharmacy. Not your local independent, not the hospital pharmacy, the PBM owns specialty pharmacy. You call to ask why. It is a specialty medication. It requires special handling. And maybe that's true, or maybe the specialty pharmacy is owned by the same parent company as the PBM, and the PBM just routed a high-margin prescription to its own subsidiary, and you have no way to know which it is. And here's the mystery. You have a prescription, the drug exists, it's FDA approved, your doctor believes it is the right therapy, your insurance is active, you're standing at the pharmacy counter. But somewhere between a doctor's order and that counter, the system says no, or says wait, or says only if you use this some pharmacy, take this other drug first, pay this price, that is 10 times what you expected. So who is making that decision? Not your doctor, not the pharmacist, not really your insurer, though they are signing the contract. The entity making that decision, controlling access, setting the price, deciding the terms, is the PBM. And to understand why your prescription gets denied, delayed, or repressed, you need to understand what a PBM is, where it came from, and where it sits in the drug supply chain. So, what is a pharmacy benefit manager? The former definition, a PBM, is a third-party administrator that manages prescription drug benefits on behalf of health insurers, employers, union health plans, and government programs like Medicare Part D. That's accurate, but it doesn't capture the power. And here's a better way to think about it. In our last episode, we talked about how United Health built Optum into a healthcare operating system, owning the insurance, the clinics, the surgery centers, the claims data, the pharmacy benefits, all under one roof, controlling the patient journey from start to end. And the PBM is the prescription operating system. It sits at the center of the drug transaction. It never manufactures the drug, it never physically handles the drug, but it controls the financial and information layer that it determines whether the transaction happens, where it happens, and at what price. Let's map the supply chain, because this is where the power becomes visible. There are 7 parties in the US prescription drug system. 1. The manufacturer, such as Pfizer, Eli Lilly, Merck, the company that invents and makes the drug. 2. The wholesaler, the distributor who buys in bulk from manufacturers and ships to pharmacies. About 85% of wholesale distribution runs through 3 companies, McKesson, Cardinal Health, and Cencora, legacy American Southbergen. These are logistic giants. They warehouse drugs, manage cold chain storage, and deliver to pharmacies. 3. The pharmacy, the retail or hospital pharmacy that dispenses the drug to the patient. Walgreens, CVS, your local independent. This is where you pick up the bottle. And 4, or maybe 3.5, the specialty pharmacy, a separate channel for high-cost complex drugs, biologics, infusion therapies, cancer drugs, often require specialty storage, patient counseling, insurance coordination, and these drugs don't get handed over at the counter drugstore. They are shipped directly to your home or administered in a clinic. 5. The payer. The employer, health plan, union, or government program paying for the drug benefit, and this is who is footing the bill. And 6. The PBM. The entity that sits between all of them, negotiating prices, managing the formulary, processing claims, deciding reimbursement. And 7. The patient, you. Now here's the critical distinction. The physical flow of the drug goes manufacturer to wholesaler, to pharmacy, to patient. The PBM never touches it. But the financial and information flow goes. Manufacturer negotiates with PBM, PBM writes the formulary, PBM sets the terms for the pharmacy network, PBM processes a claim where you show up at the counter, PBM bills the payer, your employer or health plan, PBM reimburses the pharmacy. The PBM is invisible in the physical supply chain, but it is the operating system for the financial layer, the gatekeeper, the switchboard operator routing transactions and enforcing rules. And that position power, that control over information, pricing, and access is what makes PBMs so influential. But it wasn't always this way. PBMs started in the 1960s and 70s as simple claims processors. Paper shufflers, think of them like the Visa or MasterCard of prescriptions. You'd go to the pharmacy, the pharmacist would verify your insurance card, calculate the copay, mail a paper claim to the PBM, and weeks later, the pharmacy would get a check in the mail. Administrative work. Maybe more boring, low margin, necessary, but not powerful. But by the 1990s, that changed. Computers entered the picture. Transactions went electronic. And because the PBM was sitting in the middle of all these digital claims, processing millions of prescriptions, they suddenly had something valuable, that data. They knew exactly which doctors were prescribing which drugs, how many patients were taking them, what pharmacies were charging, and they had a bird's-eye view of the entire market. And they realized, we can use this. PBMs began negotiating rebates directly with drug manufacturers. If a manufacturer wanted favorable placement on the formulary, better tier, lower patient copay, the manufacturer would pay the PBM a rebate, a percentage of the list price paid after the sale. And the rebate became a new revenue stream, separate from administrative fees, opaque, negotiated privately. And it gives PBMs leverage. By the 2000s, PBMs were building their own mail order and specialty pharmacy business, vertical integrating into dispensing. Now, they were not just negotiating on behalf of health plans, they were also owning the pharmacies where the drug was filled. And then came 2012. This is the year PBMs shifted from open formularies to exclusionary formularies. Before 2012, if your drug was FDA approved and your doctor prescribed it, it was generally covered. You might pay more for a brand than a generic, but it was on the list. After 2012, PBMs began excluding drugs entirely, saying to manufacturers, if you don't pay us a high enough rebate, we'll exclude your drug from the formulary. Your patients wouldn't have access at all. And that's when the rebate arms race began. A vice president at Novo Nordisk, one of the largest insulin manufacturers, testified that PBMs had become addicted to rebates. To stay on formulary, manufacturers had to raise list prices to fund bigger rebates. List prices went up, rebates went up, and vulnerable patients who paid list price out of pocket got crushed. By 2015, the next wave hit, full vertical integration. CVS Health acquired Aetna, a major health insurer, for $69 billion. Cigna acquired Express Scripts, the largest PBM, for $67 billion. United Health Group expanded Optum, integrating its PBM Optum Rx with its insurance division, its specialty pharmacy network, and its provider clinics. By 2020, the market had consolidated into what we now call the Big Three. CVS Caremark, owned by CVS Health, who also owns Aetna Insurance and over 9,000 retail pharmacies. Express Scripts, owned by Cigna, now the largest PBM by market share. And Optum Rx, owned by United Health Groups, which also owns the largest health insurer in the country and one of the largest specialty pharmacy networks. And together, these three PBMs control roughly 80% of all prescriptions filled in the United States. 80%. This is not a competitive market. That's an oligopoly. And because they are vertically integrated, owning the insurer, the PBM, and the pharmacy, they can steer patients to their own assets at every step. And now, to be clear, vertical integration isn't illegal, and PBMs argue it creates efficiencies, better coordination, lower administrative costs, better outcomes, and it also creates conflicts. When the PBM that writes your formulary is owned by the same parent company that owns the specialty pharmacies you are required to use, and that specialty pharmacy charges 20 or 30 or 40 times than a independent pharmacy for the same drug, who benefits? Not you, not your employer paying the premium, not the independent pharmacy that just lost your business. The parent company benefits. The vertically integrated conglomerate that owns every layer of the transaction. And that brings us to the question, how do PBMs actually make money? What is the business model? What are their revenue streams? And how do they turn that positional power into billions of dollars in profit without even touching a pill? The PBM business model had 5 core components, 5 tools in the toolkit: formularies, rebates, spread pricing, specialty pharmacy integration, and utilization management prior authorization. Let's take them one at a time, and because each one is a lever that shapes access and cost. Formularies. A formulary is a tiered list of covered drugs. It is the menu, but it is not just a flat list of yes or no. It is heavily structured into tiers designed to shape behavior, yours and your doctor's. Tier 1. Preferred generics. Lowest copay may be $5 or $10. The PBM wants you taking these drugs. They're cheap, they're high volume, low cost. Tier 2. Preferred brand name drugs. Higher copay, like $30 or $40. They were branded drugs that have negotiated favorable rebates with the PBM. The manufacturer paid to be on Tier 2 instead of Tier 3. Tier 3. Non-preferred brands. Your copay jumps significantly here, maybe $60, $80, $100. The PBM is signaling, we don't want you on this drug. It is expensive, and the manufacturer didn't pay us enough to prefer it. Tier 4 and 5, specialty drugs. This is where the financial pay rate hits. For these drugs, PBMs often shift from a flat copay to co-insurance. You're not paying $40, you're paying 25 or 30% of the drug's total cost. And if the drug costs $80,000 a year, your co-insurance could be $20,000. And think about that. The drug is on the formulary. It is technically covered, but it is economically out of reach for many patients. The PBM can effectively deny your access without saying the word no. They just place it on Tier 5, and economics does the rest. Now the PBM will tell you tier placement is evidence-based, clinical, driven by efficacy and safety. And to some extent, this is true. Generics work. They're cheaper, they've been on Tier 1. But tier replacement isn't just clinical, it's financial. If two drugs are therapeutic equivalent, they treat the same condition, they work the same way, they have similar side effect profiles, the PBM will often put the drug that pays the higher rebates on the preferred tier. Lower copay for the patient, higher rebate for the PBM. This is a formulary game. And after 2012, where PBMs started playing hardball with exclusionary formularies, the leverage shifted entirely. If a manufacturer didn't pay a high enough rebate, the PBM would exclude the drug entirely, not tier 3, not tier 5, off the list. Patients couldn't access it at all, unless they pay full cash price. And that exclusionary threat gave PBMs enormous power. 2. Rebates. Rebates are the dark matter of drug pricing, invisible to patients, opaque to employers, but absolutely central to how the system works. Here's how rebates work. A drug manufacturer wants its drugs on the PBM's formulary. The PBM says, I will put you on tier 2, preferred brand, but you need to pay us a rebate, say 40% of the list price. The manufacturer agrees. The drug gets favorable formulary placement, patients see a lower copay because it's on our preferred tier, doctors are more likely to prescribe it because patients can afford it, and after the prescriptions are filled, the manufacturer pays a PBM rebate, calculated as a percentage of the list price, multiplied by the volume of prescriptions. The PBMs then pass some or most of the rebate to the health plan or employer. In traditional contracts, the PBM might keep like 10, 15, 20%, and in newer transparency pass-through contracts, the PBM is supposed to pass through 100% of the rebate and instead earn a flat administrative fee. But here's the problem. The fundamental structural problem that drives everything else. Rebates are based on percentage of the list price. So if you are a PBM negotiating with two manufacturers, the drug A has a list price of $100 with a 30% rebate. The drug B has a list price of $200 with a 40% rebate. Which drug do you prefer? Drug B. Because 40% of $200 is $80, 20% of $100 is $30. Drug B generates more rebate revenue, even though drug A has a lower net cost to the system. And this is perverse incentive. PBMs make more money when list prices are higher, as long as rebates are high too. And manufacturers competing for formulary placement raise list prices to fund the rebates PBMs demand. And it is like hiring a real estate agent to help you find a cheap, affordable house. But their commission is paid as a percentage of the final sale price. They are supposed to help you save money, but the personal financial incentive is to convince you to buy the most expensive mansion on the block. The PBM is a buyer agent who is fundamentally addicted to higher sticker prices. Insulin is a good example. Humalog's list price rose 1,200% between 1999 and 2017. Not because Eli Lilly invested in new research and development, not because manufacturing costs increased that much, but because PBMs were demanding high rebates and Lilly raised its list price to fund them. And another insulin, Novolog, went from about $123 in 2012 to $289 in 2018. Same dynamic, rebate war. By 2019, one of the 4 insulin patients got rationing, skipping doses, splitting vials, diabetic ketoacidosis, amputations, blindness, deaths. That's what happens when rebates are based on list price instead of net prices. And there's academic evidence backing this up. In August 2024, Researcher Kate Ho from Princeton and Robin Lee from Harvard published a working paper modeling how formulary design and rebate contracts shape manufacturer pricing. In their conclusion, the structure of this contract actively inflates drug spending, manufacturers raise price to fund rebates, and PBM favors high rebate drugs over low net cost drugs. The cycle reinforces itself. And now PBM will defend this. They will say, we don't keep all the rebates, we pass most of them through the employer health plan, and 90, 95, even 100% in pass-through contracts. And this is true, but even in 100 pass-through contracts, there are carve-outs. Group purchasing organization fees, administrative fees, data fees, formulary management fees. The PBM just renames the revenue stream, and suddenly it is excluded from the pass-through requirement. It is a shell game, and rebates are just one revenue stream. And 3. Spread pricing. Spread pricing is simpler and more direct. Here's how it works. The PBM negotiates a reimbursement rate with a pharmacy, let's say $2 for a specific generic prescription. Then the PBM turns around and bills the employer health plans $2.50 for that same prescription. The PBM keeps the 50-cent difference, that is the spread, and multiplied by millions of prescriptions. You're talking about real money. According to a FTC interim report in July 2024, the big three PBMs collectively earn about $1.4 billion through spread pricing practices between 2017 and 2022. $1.4 billion just from the spread, just from the difference between what they pay the pharmacy and what they charge the plan. Now, spread pricing isn't illegal, but it is opaque. The employer paying the bill often can't see what the PBM really paid the pharmacy. The contract doesn't disclose it, so the employer has no way to verify whether the PBM is charging a fair price or paying the margin. It is the rent extraction by information asymmetry. The pharmacy knows what it got paid, the employer doesn't know what it was charged, and the PBM sits in the dark middle, keeping the spread. And in January 2025, the U.S. Office of Personnel Management, which oversees federal employee health benefits, bans spread pricing entirely for federal plans. They now require pass-through transparency pricing. What the PBM pays the pharmacy is what the PBM charges the plan, no spread. This is the direction policy is moving, but for most of the commercial market, spread pricing is still standard practice. Specialty pharmacy integration. This is where the real money is. This is the profit center that is driving billions of revenue for the big three. Specialty drugs accounted for about only 2 or 3% of all prescriptions. However, they represent roughly 50% of total drug spending. We're talking about biologics, cancer therapies, drugs for real disease, drugs that cost $30,000, $5,000, $100,000 or more per year. These drugs often require special handling, cold storage, patient counseling, prior authorization, insurance coordination, adherence support. So they dispense through specialty pharmacies, not your neighborhood Walgreens. And here's the key. The big three PBMs own the largest specialty pharmacies in the country. CVS Specialty, Accredo owned by Cigna, Optum Specialty owned by the United Health. And when you need a specialty drug, the PBM's formulary rules often require you to fill it at the PBM's own specialty pharmacy. You can't use an independent, you can't use a hospital pharmacy, you have to use theirs. And then the PBM reimburses on specialty pharmacies at a rate that is vastly higher than what it would pay for independent. How much higher? According to the FTC December 2024 report, PBM-affiliated specialty pharmacies received reimbursement that was 20 or 40 times higher than what independent pharmacies receive for the same specialty generic drugs. 20 to 40 times. Between 2017 and 2022, The big three PBMs made an additional $7.3 billion from specialty generic drug markups. $7.3 billion. This is not a rounding error. This is the business model. And because the PBM, the specialty pharmacies, and often the insurer are all owned by the same parent company, the money just flows between subsidiaries and never leaves the building. United Healthcare member, Optum Rx formulary, Optum specialty pharmacy dispensing, every dollar stays inside United Health Groups. The employer pays a premium, the patient pays co-insurance, and the vertical integrated captures the margin at every step. Independent pharmacies call this steering. The FTC called it a conflict of interest. The PBMs call it care coordination. You can decide what to call it, but the numbers are clear. Prior authorization and step therapy. We touched on this before, but now you can see the financial logic behind it. Prior authorization is supposed to ensure that a drug is medically necessary, and step therapy is supposed to ensure that patients try lower-cost alternatives first. Both sound reasonable, sound clinical, but in practice, they are often tools to protect the formulary. If your doctor prescribes a drug that is not on preferred tier, maybe because it doesn't pay a high rebate, the PBM requires prior authorization. Your doctor has to call, submit paperwork, justify the prescription, wait for approval. And often, the answer is denied, but the patient needs to try this other drug first. What other drug? The one on the preferred tier, the one that pays a high rebate. And that always what's happening? No. Sometimes prior authorization does prevent improper use. Sometimes step therapy does save money without compromising outcomes. Sometimes the preferred drug really it is just as effective and cheaper. But when 70% of patients report insurance denied, that delayed or prevented care, when Medical Advantage plans alone made 53 million prior authorization determinations in a single year. It is hard to argue that it is just about clinical appropriateness. It is also about protecting the revenue model, about steering patients toward rebate-generating drugs, about rationing by inconvenience. And let's summarize. Formularies control access. Rebates create hidden revenue streams tied to list prices. Spread pricing captures margin around opacity. Specialty integration drives profit by steering to own pharmacies at inflated markups. And prior authorization protects the formulary by creating barriers to non-preferred drugs. This is the toolkit, and this is how the machine works. Now the question is, how did PBMs get so powerful to deploy this toolkit across 80% of US prescriptions? The story of PBM power is the story of 5 forces working together: employee dependence, Medicare Part D, specialty drugs, scale, and vertical integration. Let's start with employers. Most Americans get health insurance through their jobs, and most employers, especially large ones, are self-insured, meaning they pay claims directly rather than buying a fully insured plan from a carrier. For those employers, managing prescription drug benefits is complicated. You need pharmaceutical expertise. You need to negotiate with manufacturers who have monopoly power over their patent drugs. You need to build a pharmacy network covering every geography. You need to process millions of claims in real time. You need to analyze utilization data, identify waste, provide fraud. Most employers don't have that capacity in-house, so they hire a PBM. The PBM says, we'll handle everything, we'll negotiate discounts you can't get on your own, we'll manage the formulary, we'll build the network, we'll process the claims, we'll deliver guaranteed savings through rebates. Sounds great. except employers are trusting the middleman, and the middleman has more information than the employer does. The employee can't see what the PBM actually pays the pharmacy, can't verify the size of rebates, can't audit whether the PBM is maximizing net cost savings or maximizing rebate revenue, which is, as we just discussed, are not the same thing. According to Brookings institution scholars who've studied PBM contracting, this is a classic principal-agent problem. The employer, the principal, hires the PBM, the agent, to act on their behalf. But the PBM's incentives don't perfectly align with the employer's goals. The PBM profits from high rebates, the employer benefits from low net costs. Those aren't always the same, and because the contracts are confidential, complex, and 200 pages long, most employers can't effectively oversee what the PBM is doing. And there's even been a wave of class action lawsuits against Fortune 500 employers, alleging they breached their fiduciary duty under ERISA, the Employee Retirement Income Security Act, by failing to oversee PBM fees. Some of those lawsuits claim PBMs mark up certain drugs by 5,000, even 10,000%, and the employers didn't catch it because they lack audit rights or pharmaceutical expertise. Now employers can choose pass-through pricing models where the PBM passes 100% of rebates to the plan sponsor and earns only administrative fees. That's more transparent, but even in pass-through contracts, these are gaps. Group purchasing organization fees, specialty pharmacy markups, and the employer still depends on the PBM for formulary design, network access, and claims processing. Dynamic remains. The employer needs the PBM more than the PBM needs any single employer. And that is the first force, employer dependence. The second force, Medicare Part D. In 2006, Congress created Medicare Part D, the prescription drug benefits for seniors. Suddenly, 60 million Americans had drug coverage who didn't before. But here's the key design choice. The federal government didn't negotiate drug prices directly, the way the VA does for veterans. Instead, Medicare pays private Part D plans, and those plans hire PBMs to manage the benefit. And overnight, PBMs had governance-scale leverage. They are now negotiating on behalf of the largest payer in the country, and the federal government was, in fact, subsidizing the PBM business model. Taxpayer dollars flowing through Medicare to private plans, to PBMs, to rebates. Medicare Part D standardized formulary tiers across the industry, normalized rebates as the primary pricing mechanism. It created a high-cost specialty tier, Tier 5, with coinsurance instead of flat copays that shifted costs to patients. And it gave PBMs a massive new revenue stream funded by taxpayers. To be clear, Medicare Part D expanded access. Millions of seniors got drug coverage who didn't have it before. That's important, that matters. But it also locked in the PBM model. It made PBMs the de facto infrastructure for prescription drug benefits in the US, public and private. Third force, specialty drugs. In the 1990s and early 2000s, most drugs were small molecules, pills, generics, relatively low cost. By the 2010s, the market had shifted. Biologics, gene therapies, cancer immunotherapies, drugs for real diseases, often drugs developed for tiny patient populations but priced at hundreds of thousands of dollars per patient. These drugs are expensive. $30,000 a year, $80,000, $500,000 for a one-time gene therapy. And they represent about half of all drug spending in the United States, despite being only 2 or 3% of prescriptions. And that shift creates a profit opportunity for PBMs. They built or acquired specialty pharmacies. They created specialty tiers with high patient cost sharing. They used formulary exclusions to extract rebates from specialty manufacturers, just like they did with insulins and other high-volume drugs. And because specialty drugs often require patient support programs, helping patients navigate insurance, manage side effects, coordinate refills, the PBMs argue that only the specialty pharmacy improves care coordination. Maybe it does, but it also creates a vertical profit stream that's nearly impossible for employers to audit. The PBM writes the formulary. The formulary requires a patient to use the PBM specialty pharmacy. The specialty pharmacy is billed at 20 or 40 times what an independent would charge, and the parent company captures the margin. The FTC found that this arrangement added $7.3 billion in costs between 2017 and 2022, and that flowed from patients and employers to PBM parent companies. First force, scale. PBMs are a scale game. The bigger you are, the more leverage you have. If you control 80% of prescriptions, you can tell pharmacy chain, accept of reimbursement rates, or lose access to 80% of your customers. You can tell drug manufacturer, pay this rebate, or we'll exclude your drug from the formulary and your patients wouldn't have access. Employers and health plans want to work with the biggest PBMs because they assume bigger means better negotiation power, better discounts, better rebates, and better savings. So the big three keep growing. Express Scripts is now the largest PBM by market share. CVS Caremark is second. Optum Rx is third. Together, they control about 80% of the market. This is not a competitive market. This is concentration. And scale creates network effects. The more members you have, the better rates you can negotiate, the more attractive you are to new clients. And the cycle reinforces itself. And which brings us to the fifth force, vertical integration. We talked about mergers, CVS and Aetna, Cigna and Express Scripts, United Health and Optum. But vertical integration isn't about ownership, it is about control. When the insurer, the PBM, the specialty pharmacy, and sometimes even the physician clinics are all by the same parent company, every transaction stays in-house. The insurer decides which PBM the plan will use. Well, it is the one they own. The PBM decides which pharmacies the patient must use. Well, the one they own. The specialty pharmacy dispenses the drug at a markup, and the money flows between subsidiaries. And it is not a market transaction. It is an internal accounting entry. And that opacity is the point. When Optum Rx routes a prescription to Optum specialty pharmacies, what is the market price for the service? There isn't one. It is whatever United Health Group says it is. Employers and patients can see it, regulators struggle to audit it, and the profits stay inside the empire. A white paper from USC Sheffield Center in January 2026 noted that vertical consolidation allows companies to upscale PBM profitability through transfer pricing. The money moves between units, but you can't tell from the outside whether PBM is profitable or the specialty pharmacy is profitable, or both. You just know the parent company is making money. And from recent policy dynamics, we got a signal that powerful vertically integrated players are feeling pressure. And that brings us to the debate, because for all the power PBMs have accumulated, for all the billions in rebates, spreads, and specialty markups, they are now facing the most intense scrutiny in their history. Critics say PBMs are hidden toll collectors, extracting rents and inflating prices. Defenders say they are cost savers, using scale to negotiate discounts employers couldn't get along. So who is right? Let's start with the critics. In September 2024, the Federal Trade Commission sued the big three PBMs, CVS Caremark, Express Scripts, and Optum Rx, alleging they had created what the FTC called a perverse drug rebate system that artificially inflated insulin prices and harmed patients. The lawsuit argues that PBMs use their formulary power to favor high rebate insulin over low-cost alternatives, driving up list price and harming patients who had to pay those prices out of pocket, the uninsured, underinsured, anyone in a high deductible plan. The House Oversight Committee released a report in July 2024 documenting what lawmakers called severe anti-competitive practices in PBM rebate negotiations. The FTC interim report, also from July 2024, found that Big Three earned $7.3 billion from specialty generic markups and $1.4 billion from spread pricing between 2017 and 2022. Independent pharmacies have filed class action lawsuits alleging that PBMs impose one-side contracts with below-cost reimbursement, forcing pharmacies to fill prescriptions at a loss or lose network access entirely. State legislators in Ohio cited PBM practices as a primary driver of pharmacy deserts. Rural and underserved areas where independent pharmacies have closed, leaving communities without local access to medications. And patient advocacy groups argue that prior authorization delays care, that formulary exclusions brought access to needed medications, and that copay accumulator programs, where manufacturer assistance didn't count towards a patient's deductible, leave vulnerable patients shouldering costs they couldn't afford. The critics' case, in short, PBMs inflate drug prices through the rebate game, they squeeze independent pharmacies through below-cost reimbursement, they steer patients to own specialty pharmacies at inflated markups. This obscure pricing through vertical integration and control opacity. And they harm patients and employers through information asymmetry and misaligned incentives. Now, let's hear the defense. PBMs argue that they use their scale to negotiate discounts that employers and health plans couldn't achieve on their own. Without PBMs, the argument goes, employers would pay full list price, no rebates, no formulary leverage, no ability to drive generic utilization, or prevent wasteful spending. PBMs also point out they've driven the generic dispensing rates to about 90%. 90% of prescriptions filled in the United States are generics, not branded name drugs. They save billions, and PBMs deserve credit for creating formulary incentives that promote generics. They argue that rebates do get passed through to plan sponsors, 90, 95, even 100% in pass-through contracts, and that the net price of drugs after rebates has grown more slowly than list prices. The vulnerable patients who pay list prices are harmed, yes, but the majority of patients benefit from low premiums funded by rebate savings. They argue that formularies and prior authorization promote appropriate use, prevent waste, and ensure patients try low-cost alternatives before jumping to expensive therapies. Without these tools, they say, doctors would prescribe the newest, most expensive drug for every condition, and healthcare spending would spread out of control. And they argue that vertical integration improves care coordination, especially for complex specialty drugs that require patient counseling, adherence support, and insurance navigation. So who is right? Analysis comes from Brooklyn Institute scholars, published a review in September 2023 titled A Brief Look at Current Debates About Pharmacy Benefit Managers. Their conclusion, PBMs are not inherently harmful. They can reduce costs through scale and manufacturer computation. But current practices, especially opacity, rebate retention, and vertical integration, create legitimate concerns about conflicts of interest, information asymmetry, and harm to vulnerable patients. In other words, PBM can be cost savers and tool collectors. It depends on the contract, it depends on the transparency, it depends on the incentives. The problem isn't that PBM exist. The problem is the rules governing how they operate. And right now, those rules are being rewritten. In February 2026, the FTC announced what it called a landmark settlement. The terms are still emerging, but it may require structural changes. Greater rebate transparency, limits on specialty pharmacy steering, restrictions on spread pricing, independent auditing rights for employers. All 50 states have passed PBM legislation in the last 2 years. Some require disclosure of maximum allowable cost lists, the rates PBMs pay pharmacies. Some mandate rebate pass-through, some prohibit certain steering practices, and some create PBM licensing requirements and give state regulators audit authority. The Department of Labor has proposed new transparency rules for PBMs serving ERISA governance employer plans, requiring disclosures of all fees, rebates, and spreads. If finalized, employers will finally be able to see what they are actually paying for. And CVS, the Centers for Medicare and Medicaid Services, has finalized rules requiring faster prior authorization decisions and point-of-sale rebates in Medicare Part D. So patients benefit from rebates at the pharmacy counter instead of insurer capturing them on the back end. The pressure is real. The scrutiny is unprecedented. The question is whether it is enough, because transparency doesn't eliminate the fundamental dynamic. PBMs still control the formulary, they still process the claims, they still own the specialty pharmacies, they're still the operating system. And that brings us to the final question. Who really controls your prescription? So let's answer this question. If your doctor writes a prescription, who actually decides whether you got it, where you fill it, and what you pay? Your doctor writes it based on clinical judgment, medical evidence, your history. The manufacturer makes it, spending billions on research, development, clinical trials. The pharmacy dispenses it, counseling you on how to take it, checking for drug interactions, ensuring it is safe. But the PBM decides whether it is covered, the PBM decides what tier it is on, and therefore what your copay is. The PBM decides whether you need prior authorization before your doctor's prescription is honored. The PBM decides whether you have to try a different drug first and fill on it before accessing the prescribed therapy. The PBM decides which pharmacies are in network and increasingly whether you are required to use PBM's own specialty pharmacy instead of your local independent or hospital pharmacy. The PBM negotiates a rebate with the manufacturer, shaping which drugs get preferred formulary placement. The PBM sets a spread between what is paid to a pharmacy and what it charges your employer. The PBM writes the formulary rules. The PBM defines the terms of access. And if you are an employer paying the bill, a patient trying to fill a prescription, or an independent pharmacy trying to stay in business, you're operating inside a system where the PBM has more information than you do, more leverage than you can match, and financial incentives that may not align with yours. And this is the control map. The drawer, legally, your employer or health plan contracts with the PBM and sets the high-level benefit design. They decide whether to offer 3-tier or 5-tier formularies, what the deductible is, what the out-of-pocket max is. De facto, in practice, the PBM controls the transaction. And now, does that mean PBMs are the villain in this story? Not necessarily. PBMs exist because the US drug supply chain is fragmented. Manufacturers, wholesalers, pharmacies, insurers, and employers all operate separately. There's no single payer, no central negotiator, no one entity responsible for end-to-end coordination. Someone has to sit in the middle. Someone has to aggregate demand, negotiate prices, manage formularies, process claims, analyze utilization, prevent fraud, and that's what PBMs do. The question is, what rules should govern them? Should rebates be based on list price or net price? Should PBM be allowed to own specialty pharmacies and steer patients to their pharmacies at markups 20 or 40 times higher than the independents? Should spread pricing be permitted, or should all contracts be pass-through transparent? Should prior authorization be subject to time limits, external clinical review, and automatic approval if the PBM doesn't respond within a certain time window? Should employers have the right to audit PBM contracts, say pharmacy reimbursement rates, and verify rebate calculations? Should PBMs be subject to fiduciary duties under ERISA, legally required to act in the best interest of the plan and their members rather than maximizing their own revenue? Those are policy questions, and right now in 2026, policymakers are trying to answer them. The FTC lawsuit is ongoing. The February settlement may set a precedent for structural reforms across the country. 50 states have passed laws creating new disclosure requirements, licensing regimes, and enforcement mechanisms. The Department of Labor is proposing transparency mandates that could fundamentally reshape ERISA plan contracting. But here's the reality. Even if every one of those reforms succeed, PBMs still exist. They will still be the operating system. What is changing is the transparency, the oversight, the constraints on certain practices, the ability of employers and regulators to audit what PBMs are actually doing. The likely future, it is not PBMs disappear, it is PBMs operate under stricter rules. And that means the fundamental dynamic where the PBM sits between your doctor's clinical judgment and your access to the drug will remain. So what does this mean for patients? It means you need to understand that your insurance card is not a guarantee of access. It is a gateway to a negotiation you didn't know you were part of. It means if you're denied, you should appeal. Many denials are overturned on appeal, especially if your doctor submits additional clinical documentation, but many patients don't know that or don't have the time and energy to fight. It means if you are in a high deductible plan, you are paying less price until you hit your deductible, and you are not benefiting from rebates that flow to insurer or employer on the back end. So manufacturer copay assistance programs, discount cards, and patient advocacy foundations may be your better options for affording expensive medications. It means you should ask your employer, what kind of PBM contract do we have? Is it pass-through or traditional? Can we see the rebates? Can we audit the pharmacy reimbursement rates? Can we verify the specialty pharmacy markups? Most employees don't ask those questions, but they should. For employers, it means that if you are self-insured and you hire a PBM, you need to understand that PBM is not a neutral administrator. It is a business with its own revenue model, its own profit incentives, its own conflicts of interest. You need transparency, you need audit rights, you need to know what the PBM is paying the pharmacy, what rebates it's collecting, whether the specialty pharmacy is charging a market rate, or markup designed to enrich the parent company. And you need to recognize that the biggest PBMs are vertically integrated with insurers and pharmacies. When you hire them, you're not just hiring a middleman. You're buying into an ecosystem where the PBM's parent company profits at multiple points along the chain. And your ability to audit those profits may be contractually limited. For drug makers, it means the rebate treadmill isn't going away. As long as formularies are exclusionary and rebates are based on list price, manufacturers will face pressure to raise list prices to fund rebates just to remain formulary access. The FTC has put manufacturers on notice. If your rebate practices contribute to artificial inflative prices that harm patients, you could be the next in the enforcement wave. And for independent pharmacies, the outlook is grim. Below cost reimbursement, steering to PBM-owned channels, contract terms that change without notice, with no ability to negotiate. It is not a sustainable model. Some states are passing laws to protect pharmacies, requiring PBMs to reimburse at or above acquisition cost, banning certain steering practices, mandating transparency in maximum allowable cost lists. But in a market where the big three control 80% of prescriptions and own their own pharmacy networks, independent pharmacies are fighting an uphill battle. And here's the synthesis. In episode 1, we talk about why US healthcare is so expensive. One reason, intermediaries. Layers of middlemen, each taking a cut. $41 of every 100 spent on drugs going to intermediaries rather than manufacturers or pharmacies. In episode 2, we talk about why US healthcare is so fragmented. No single payer, no central negotiator, a system built on decentralized contracting, employee-sponsored insurance, and market competition that doesn't function like a normal market. In episode 3, we talk about how private insurers became operating systems, vertically integrating across insurance, clinics, pharmacies, and data to control the patient journey and capture revenue at every step. Episode 4 is the logical next step. PBMs are the prescription operating system. They are the hidden layer between clinical intent and patient access. They exist because the system is fragmented, because someone needs to aggregate demand, negotiate prices, process claims. They profit because the system is opaque, because contracts are confidential, rebates are undisclosed, vertical integration obscured intercompany pricing, and they control prescription access not through ownership of the physical drug, but through ownership of the formulary, the rebate contract, the pharmacy network, the claims data, and the rules that govern whether a transaction happens. That is the answer to the question, who really controls your prescription? Not your doctor who writes it based on clinical judgment, not you, the patient who needs it to stay healthy, not even your employer or insurer who pays for it but can't always audit what they are paying for. The PBM controls it. And until the rules change, until transparency replaces opacity, until rebates are based on net prices instead of list prices, until vertical conflicts are addressed, until employees have true audit rights and enforced mechanisms, the PBM will continue to be the most powerful, least understood player in the US healthcare. This is Summer Lens. Thanks for listening.